Good afternoon, everyone. Welcome from the Department of Gastroenterology. Today in CGR, we are presenting the title is The Art of Diagnosing Crohn's Disease in TB Endemic. Now, as you all know, Crohn's disease is an eponymous disease. It's an eponym named after Burrell Crohn, Dr. Burrell Bernard Crohn. Now, the good thing is, or what I would say the interesting part is, let me say it is part of academic folklore, but I can tell you that it has been verified very much. Dr. Burrell Crohn, he visited AIIMS. He visited AIIMS somewhere in late 1960s. At that time, Professor Atam Prakash, who was head of surgery, was doing a lot of work on intestinal tuberculosis. And along with him were Professor H.D. Tandon, who later on became the director of AIIMS. And so, Professor Atam Prakash, Professor H.D. Tandon, when they realized that Dr. Crohn is very much in person there, they thought that let's show him all the specimens, the surgical specimens, the pathology, and ask him whether Crohn's can be there in India or not. Because when they went to clinics, they did not find any case of Crohn's at all. Dr. Crohn went through the pathology specimens. He is a gastroenterologist, not a pathologist, but he went through the specimens along with Dr. H.D. And they had collected around 70 specimens or something where they were not able to decide because it was not fitting into TB at all. Yet at the same time, they felt it was TB. It was neither fitting in Crohn's and more than Crohn's they thought was not present. Dr. Crohn very categorically refused that those are not cases of Crohn's. And subsequently, in that paper, the paper which was published in 1970, they published Dr. H.D. Tandon, Dr. Atam Prakash, they published only 3 cases of Crohn's and just 120 cases of tuberculosis. They came up with another seminal paper 2 years later in 1972, where they had 10 cases of Crohn's, but in 1970, they themselves were confused, perplexed, and you can say the confusion gathered has started right from that. For next 25 years, not much work was done on it because work was not required. We were not having so many cases of Crohn's disease. Came the 2000, and subsequently what we find is an epidemiological transition. Epidemiological transition in the form that you find non-communicable diseases coming up, organ-specific autoimmune diseases coming up, and obviously you saw a surge of Crohn's disease. Whether it was undiagnosed before or it had just come up, nobody knew. But along with it, in the middle of it, it brought the major problem. What Burrell Crohn, Professor Atam Prakash, Professor H.D. Tandon were perplexed, totally confused in 1970s. Right now, it was for the millions now to decide what to do about it. And so, today we present how systematically the department has chipped into this problem, systematically I would say, along with the department, with the help of Department of Pathology, Department of Radiology, Department of Microbiology, Department of GI Surgery. And so today we have many small talks. Why many small talks? Because you realize that most of the speakers out here, they have actually provided seminal contributions in this field. They have provided, I would say, outstanding contributions in this field. They have provided contributions which are there not only from AIIMS but from India and have become part of various guidelines. So I start with the first star speaker. I invite Dr. Saurabh Kedia from our department to talk about Crohn's.
Good evening, everyone. Thank you, sir. So I'll start briefly with the introduction of what is inflammatory bowel disease. So it's an immune-mediated chronic inflammatory condition of the intestine. It has 2 subtypes: ulcerative colitis and Crohn's disease. Ulcerative colitis is a disease which involves only the colon in a contiguous fashion, and the inflammation there is limited to the mucosa. And Crohn's disease can involve any part of the intestine. It can have multiple segments involved, and the inflammation in Crohn's disease is usually transmural. It can involve all the layers of the intestine. So, as Dr. Vineet said, similar to Crohn's disease is the intestinal TB, which also can involve multiple segments in the intestine, which also can cause transmural inflammation and behave similarly to Crohn's disease. So, what's the pathogenesis of IBD? IBD basically is an aberrant immune response against the gut microbiome in genetically predisposed individuals. And this gut microbiome is modified by the environmental factors which include diet and the lifestyle. So, how have these diseases evolved over the last century? So, we see this map in the 1900, the areas such as the Northern America and Western Europe, which were dominated by the tuberculosis and in high tuberculosis mortality, 100 years later, they are replaced by Crohn's disease. So the TB declined in this area and Crohn's disease emerged. And if you look at this graph, then with the decline of tuberculosis in the West, such as in the Cardiff Bay and in Minnesota in the USA, there was emerging or a rising incidence of Crohn's disease. And another interesting observation is, and if you look at the time span between the World War I and World War II, the tuberculosis began to decline before the emergence of anti-tubercular therapy. So the possible reason for this decline was the improvement in the sanitation, improving hygiene, and improving in the lifestyle conditions. So the good thing about this change was the decline in infectious diseases, but the price which these countries paid was the rise in the non-communicable or the Crohn's disease or the inflammatory bowel disease. If you look at the global epidemiology of IBD, IBD emerged in the middle of 19th century in the West and has been gradually increasing in incidence, peaking over the last 2 decades. While in India and the other Asian countries or in the developing countries, IBD emerged 100 years later and has now been gradually increasing in incidence in this area, probably because of the change in the diet, change in the lifestyle, improvement in the sanitation and industrialization. What about India? The augury of India was highlighted 10 years back in this editorial when the emergence of Crohn's disease was identified with its existence with the infectious disorder of the intestinal TB. So, although inflammatory bowel disease is an example of the epidemiological transition with the decline in infection and increase in the non-communicable diseases, but India still is at the epidemiological crossroads with the existence of infectious disorders such as intestinal TB and inflammatory disorders such as Crohn's disease. Subsequently, we defined or we compared the epidemiology of IBD in India with the other Asian countries, and we also characterized the features of Crohn's disease from 3 centers of India. Now, what about the epidemiology of IBD or the disease burden of IBD in India? IBD has been considered the disease of the West, the developed region, the rich nation, and has been emerging in the developing world. So, if we look at this figure, although the prevalence of IBD in India is still not as high as that of the West, but if we consider the overall Indian population, then the number of IBD cases in India is higher than almost all the countries of the Europe and is almost equal to USA, being almost the highest in the world. India has a huge burden of IBD, which, along with intestinal TB, is perplexing the physicians today. Now, how do we diagnose these disorders? Crohn's disease is diagnosed with a combination of clinical, radiological, histological, and endoscopic features. But the problem is there is no gold standard for the diagnosis of Crohn's disease, and there is no feature which is either exclusive or specific to Crohn's. TB, which is a mimic of Crohn's, is also diagnosed similarly, but because it is an infectious disorder, the microbiology plays an important role, and the diagnostic criteria were laid in 1959, where the TB was definitely diagnosed in the presence of either characteristic histological feature of physician necrosis or the microbiological demonstration of either acid fast bacillus or a positive culture. However, the caveat with the diagnostic criteria is the low sensitivity. Intestinal TB is a possibacillary disease, so these features are identified in a minor proportion of patients, as highlighted in this study, where in among 37 patients, only 7 patients had a definitive diagnostic criteria. So to circumvent this issue, 10 years later, you again modified these criteria and added 2 additional features, either a demonstration of tuberculosis elsewhere in the body or a positive response to anti-tubercular therapy without any development of Crohn's disease during follow-up. So this is how the diagnosis of Crohn's disease and tuberculosis has emerged over the decades. Now, to summarize this, Crohn's disease and intestinal TB are phenotypically similar. In Asia and India, both these disorders coexist as present. TB is difficult to diagnose because it's a possibacillary disease, and Crohn's disease is difficult to diagnose because there is no gold standard for the diagnosis of Crohn's disease. Now, how do we treat the disorders and why is it important? TB is an infectious disorder treated with ATT. Crohn's disease is an inflammatory disorder treated with immunosuppression. But if you are unable to distinguish, if you are unable to identify, then what can be the consequence? So, if intestinal TB is treated with immunosuppression or is treated as Crohn's disease, there is a risk of flare of TB. If Crohn's disease is treated with ATT, then there is a risk of unnecessary ATT immunosuppressive toxicity and or probably worsening disease course of study, which will be highlighted later. So, over the years, we have evolved our algorithm or diagnostic ladder for diagnosing and differentiating different disorders, starting with the clinical features, followed by endoscopy and histology, the place of radiology, and the place of other studies. To discuss the clinical features, I would like to invite Dr. Crohn. Thank you. Thank you, Saurabh. Thank you so very much. So, as we discussed, that what are the, there's a lot of similarity between tuberculosis and Crohn's disease. So, how do we see this? For a clinician, symptom is the first contact. The contact between patient and doctor is symptoms. The symptom is the first contact where patient comes to us, and we as a physician recognize the disease based on pattern of symptom. So our practice is based on pattern recognition, like symptom recognition, and based on symptom combination, the natural history of symptoms, we decide that this is a particular disease A or disease B, and we draw a differential diagnosis. So as a clinician, symptom recognition and the pattern of symptom is extremely important for us. So what are the features of tuberculosis Crohn's disease? So there's always a spectrum. In the early part of disease, there are no symptoms. As you know, the intestine, if there are inflammation, as Saurabh said, it's a chronic inflammatory disease. So there will be inflammation in the intestine. There will be some ulcers, but the ulcers may bleed, but bleed may not be visible to patient. Unless the disease becomes so severe that there is a stricture formation, then they will come to us as pain. So early part of both tuberculosis and Crohn's disease are generally asymptomatic. They can have symptoms, but they're not known to patients. They can have bleeding. Bleeding is an occurred blood, and they will not be obvious blood when patient can see. Therefore, there will be always a spectrum of symptoms. So two things: both tuberculosis and Crohn's disease are chronic disorders. They are inflammatory in nature. Therefore, with time, there will be change in the pattern of disease from a mucosal disease to a stricture disease. The symptom will change. Initially, there will be only mucosal symptoms, but as disease advances, there will be stricture formation. And also, in Crohn's disease, is a transmural which can penetrate and lead to fistula formation between intestine to intestine or intestine to perineum, leading to perineal fistula. So this symptom will be like this. So look at both. First, look at tuberculosis. Tuberculosis generally is a unifocal disease. Only one part of intestine is affected, whereas Crohn's disease is generally a multifocal disease. They can have multiple segments of disease of intestine can be affected. Both can have obstructive features, and TB generally presents like obstructive feature. If there is ulcer in the intestine, they are never symptomatic. And patient comes to us when the intestine becomes so strictured that they have patient intestinal colic or obstructive features. They can have inflammatory features in terms of fever or joint pain. They can have consular symptoms like weakness, irritability, and they can also have extra-intestinal manifestations, both in Crohn's and tuberculosis. In addition, one important feature we distinguish TB and Crohn's is the mucosal symptoms. As I said, the Crohn's disease is a multifocal, but they can also have involvement of the left side of colon. And therefore, if there is ulcer out here, it can bleed, and the patient comes to us with a diarrhea and bleeding. So this is very important manifestations which helps differentiating tuberculosis and Crohn's disease. And putting them together, all these symptoms, there are multiple papers from our institution, and summary of that those who have Crohn's disease, they have a more diarrhea. None of these features are sacrosanct of tuberculosis or Crohn's disease. All of them can occur in both disorders. But looking at pattern of their presence in these disorders, diarrhea and bleeding per rectum is distinctly more common in patients with Crohn's disease compared to tuberculosis. Furthermore, the abdominal pain and features of intestinal colic, intestinal obstruction can occur in both. We have both a chronic inflammatory disease with the intestinal obstruction. And one important thing is different because Crohn's disease being a penetrating disease, it leads to perineal disease in terms of either hemorrhoids or fissure or fistula, on which distinguishes. And last one is extra-intestinal manifestations, which are certainly more common in those who have Crohn's disease. So again, the Saurabh summarized all of these studies from our center and for mainly center from Korea and China. And again, we have almost similar pattern of manifestation in two. So those who have a disease in the left side symptoms, like those who have diarrhea and urticaria, it favors the diagnosis of Crohn's disease. Now coming to extra-intestinal manifestation, as the author said that this autoimmune disease, so they do have multiple other features elsewhere in the body, including arthralgias, which could be both peripheral and central. They can have multiple skin manifestations. They can have arthrotic manifestations in terms of psoriasis, uveitis, and they can also have a thromboembolic manifestation. But these are more common in Crohn's disease compared to tuberculosis. When you look at any extra-intestinal manifestation, almost 40% patients with Crohn's disease have any of these manifestations, and only 14% in tuberculosis. And those who have Crohn's disease mainly have multiple, at least multiple extra-intestinal features. So these are the pointers, the clinical pattern, symptom pattern, which helps with the differentiation. And one more point I want to highlight out here, that those who have tuberculosis can also have involvement of lungs, so they can have features of pulmonary tuberculosis, either active or passive, and they can also, if there is a peritoneal disease because of tuberculosis, they can have ascites. So these are the features that we have to differentiate. So in summary, those patients, how to differentiate based on symptoms in my clinic. So those patients who comes to a intestinal obstruction, like pain abdomen, but if they also have diarrhea and bleeding, then I would favor the diagnosis of Crohn's disease over tuberculosis. One. Number two, they have longer duration symptoms. Crohn's disease generally is long, 5 years, 7 years, 3 years history. Tuberculosis generally is a shorter duration symptoms. And if they have extra intestinal manifestations, they do favor diagnosis of Crohn's disease. With this, we invite our colleague, Dr. Mitra, to take it further.
Thank you, sir. I will discuss the endoscopic evaluation part. Intestinal tuberculosis and Crohn's disease both are ulcer-constrictive disease of intestine, and both involves intestinal mucosa. So endoscopy has a role to play. And the most classical endoscopic picture described in Crohn's disease is this deep longitudinal ulcer and steep areas of involvement. And when these ulcer heals, they produce this classical cobblestoning appearance in patients with Crohn's disease. We can see this kind of aphthous ulcer commonly in patients with Crohn's disease. Whether in tuberculosis, the ulcers we found more often are transverse ulcer. More often intestinal tuberculosis involves in the ileocecal area. This can produce patulous IC valve with surrounding ulcers. In intestinal tuberculosis, we can also found this kind of circumferential ulcer and luminal narrowing. With these features, we will also take biopsy to confirm tissue diagnosis, and we also should keep in mind we should take 5 to 7 good quality biopsy for proper evaluation. So in Crohn's disease, more often it is a multifocal involvement. More often the ulcers are longitudinal, or we can say aphthous ulcer, and there will be cobblestoning. In intestinal tuberculosis, it is more often segmental or unifocal involvement involving IC valve area, and ulcers are transverse. But all these features, I say, are not exclusive of Crohn's disease or ITB. These features can overlap, and we can do multiple colonoscopy and endoscopy. We can take biopsies, but more often we will have something that will suggest a diagnosis rather than establish our diagnosis. So all these are soft points, as this base seen in this picture, where there is transverse ulcer causing a luminal narrowing, mimicking a diagnosis of intestinal tuberculosis, but patient finally diagnosed as a case of Crohn's disease. And this patient who have a classical cobblestoning appearance in endoscopy, but patient ultimately diagnosed as a case of intestinal tuberculosis. So all these are soft points. This we should keep in mind when making our diagnosis, and we cannot make a diagnosis only on the basis of endoscopy. But among these soft points, the most important and pertinent is the spectrum of involvement as described by Dr. Govind. The involvement in tuberculosis is focal, and it is more often in the right colon and around the IC valve area. But in Crohn's disease, the involvement is multifocal, can be diffuse, and involvement of both left and right colon simultaneously outfavors the diagnosis of Crohn's disease. So to proceed with our diagnostic ladder, in endoscopy, left and right colonic involvement, longitudinal ulcer, aphthous ulcer, cobblestoning favor diagnosis of Crohn's disease, whereas ileocecal valve involvement, transverse ulcer favor diagnosis of ITB. Now I will invite Dr. Prosenjit to further discuss histological part.
Thank you. So, as we have seen, it is not easy to differentiate it clinically as well as endoscopically. Let's see what we see in pathology. So, as we have already seen, both in Crohn's disease as well as in tuberculosis, the majority of the lesion we see in the ileocecal junction. and ascending colon. Hence, it is natural that we get biopsies from the ileocecal region very commonly with a differential diagnosis of Crohn's disease and tuberculosis. Now, see what is present in the ileum. In the ileum, we see distorted crypt architecture as well as variable length or variable size villi. Some are short and some are tall. That indicates that it is a chronic inflammatory disease. Here also we can see there are many eosinophils. Along with this, presence of eosinophils also favor. It can be Crohn's disease, but we also see in tuberculosis. We often see in both the diseases patchy inflammation, like here you can see here inflammation is very less, here inflammation is quite dense, and again there is less inflammation here. And we see lot of inflammation in the mucosal fragments. Again, it is showing patchy inflammation. Along with this chronicity, we often see features of activity like neutrophilic cryptitis, crypt abscesses, deep ulcers in both the diseases, in tuberculosis and Crohn's. Sometimes in both of the diseases, the ulcers go deep inside the muscle and it causes perforation. One feature which often help us to differentiate if it is IBD or non-IBD colitis, that is presence of basal plasmacytosis. This is commonly seen in ulcerative colitis consistently, but often it is present in Crohn's disease, but that is not all. We can see in some other chronic inflammatory disease as well as in Crohn's disease. So often this also doesn't help. This is showing submucosal dense lymphoid cell infiltrate. This is also in our study we have seen, though it is more common in intestinal tuberculosis, but disproportionate lymphoid infiltrate in the submucosal deeper layers can also be seen in Crohn's disease, and stricturing fibrosis can be present in both of the diseases. So the feature I have shown you that indicates there is a patchy chronic active ileocolitis. When we see only this, we cannot differentiate between a Crohn's disease and tuberculosis. Now there are some features which can help us to differentiate, like presence of a macrogranuloma. This is defined by at least size more than 200 micrometer in size, and for common interpretation its size should be more than diameter of a normal crypt. If we see too many granulomas seated in the deeper layer, here we can identify confluent granulomas which is situated in the muscularis propria, that often suggests tuberculosis. Here we can see 3 granulomas and same biopsy 4 granulomas. There is another submucosal granulomas here. Also granulomas mean giant cell, granulomas with necrosis suggest tuberculosis. Also you can see some of the granulomas are having lymphoid cuffing. But though we see more commonly in tuberculosis, this feature can also be present in Crohn's disease. ZN stain we commonly do in all cases when we see granuloma, but it has very low sensitivity, so it often doesn't help in diagnosis. If we get a lymph node, and if we get at least an information regarding presence of abdominal necrotic lymph node, that help us to make a diagnosis of tuberculosis. Now on the other hand, in Crohn's disease we also see granulomas, but the granulomas are of small size and they usually situated just next to a crypt, and they often destroy the crypt. That's why they are also called cryptolytic granulomas. These are called microgranulomas because their size is usually equal or less than size of a crypt diameter. But more importantly, these granulomas are very vague. In contrast to, you see, microgranulomas can also be seen in tuberculosis in the mucosa just next to a crypt, but this is quite well found. Sometimes people make mistake mucin granuloma and they interpret as a Crohn's disease. Here we can see microgranulomas in our study were present in almost both in equal frequency, both in Crohn's disease and tuberculosis. So presence of only this often doesn't help. And we have also seen sometimes presence of a macrogranuloma also in Crohn's disease. So why granulomas are present in Crohn's disease? Presence of this indicate more severe inflammatory phenotype. As you can see, in this study, we could show more polarization of the M1 macrophages, which is pro-inflammatory macrophages, around the granulomas in Crohn's disease. And also the monocyte-derived macrophages separated from the patient's peripheral blood, they also show more inflammatory phenotype. So this is in Crohn's disease. So if we see microgranulomas in Crohn's disease in tissue that indicates more severe inflammatory phenotype, and these patients may have more clinical feature. Also, on the other hand, if you see granulomas in tuberculosis, that actually gives the protective niche to this mycobacterium to survive. Here you can see we have shown that around the granuloma these are CD73 positive mesenchymal stem cells. We could show that in the mesenchymal stem cell the mycobacterium reside also. So this is very important, and they could be cultured in this mesenchymal stem cell in contrast to any other macrophages. And the macrophages in the mesenchymal stem cells, these mycobacteria also show resistance to INH and rifampicin, which are commonly given. So that indicates that these granulomas, which are not only help in diagnosis, but they have particular purpose. Like in Crohn's disease, they indicate more severe phenotype, and in tuberculosis, it gives a protective niche to the mycobacterium to survive. Now I invite Dr. Razik from radiology to present the radiological feature. Thank you.
I'll just briefly describe the role of imaging in the differentiation of intestinal tuberculosis from Crohn's disease. So, as we've already seen, TB versus Crohn's conundrum is a challenging issue, and imaging plays a significant role because imaging can assess all the bowel loops in one go, and it provides a comprehensive assessment of the pattern of bowel involvement. It can also assess extraluminal changes in the dysentery and lymph nodes, and also look for extraintestinal manifestations. Now, these are the various imaging modalities. Now, initially plain radiographs and barium-based studies were used. Now, these days, such studies are primarily of historical importance. Sonography is sometimes used for assessment of the ileocecal junction and terminal ileum, but for rest of the bowel loops, more proximally it is limited role. Currently, the main role in imaging is by use of CT or MR angiography. So, barium examinations primarily are of historical importance only, but I'll just show a few features in barium. So, the first two panels are ileocecal tuberculosis, where you can see narrowing of the ileocecal junction, conical configuration of the cecum. On the other hand, Crohn's disease tend to involve the terminal ileum with a long segment involvement. There is some cobblestoning of the terminal ileum. But since barium studies provide only very limited mucosal assessment, they are of limited value and rarely done these days. Now, CT angiography is the workhorse in the imaging of IBD because it can be quickly performed and gives very good data, very good information. So, in CT angiography, it is very important to provide adequate bowel distension. So, in the absence of distension, undistended bowel can either mask or mimic pathology. Also, we use neutral oral contrast, so we do not use positive oral contrast. So, this is because neutral oral contrast enables us to better assessment bowel enhancement. In addition, we typically use mannitol, which provides an osmotic agent, so absorbs water and provides good distension. So positive oral contrast is avoided. One disadvantage of CT is the high radiation dose. So these are coronal CT angiography images. We can see the bowel loops which are distended with this neutral contrast. We can clearly see the enhancement of the bowel wall. So avoid CT with positive oral contrast unless in the case of evaluation of postoperative bowel when you are suspecting leak or fistula. So in all these cases we can see positive oral contrast is administered, which actually limits our ability to estimate or evaluate the enhancement of the bowel. So MR angiography has several advantages. So it's primarily used as a problem solving tool when there is a doubt or when there is doubtful enhancement of on CT or in the follow-up, especially in young patients, in view of the radiation burden associated with CT. Now, the main advantage of MR is the high tissue contrast, intrinsic tissue contrast that it has, and also it enables multiple paradigms in the assessment of bowel. So, we typically use fast T2-weighted sequences like HASTE, and then we also use post-contrast T1-weighted images to look for enhancement of the bowel wall. In addition, other paradigms like cine sequences to assess live real-time peristalsis in the bowel, and also diffusion-weighted imaging, which is very helpful in assessing disease activity. So these are the MR sequences. So this is a T2-weighted HASTE sequence. We can see the fluid within the bowel is causing optimal distension. and intensely bright as compared to the wall, which is T2 intermediate. So we can see there's a very good contrast in MR as compared to CT. Also, is the same is in the case of post-contrast imaging. We can see that the bowel wall enhancement is much better appreciated on MR in comparison to CT. So these are the other images or sequences that we acquire. So we have provided recommendations in the clinical and radiological aspects of intestinal tuberculosis versus Crohn's disease. The Indian Society of Gastroenterology and IRIA has also provided joint position statements on imaging of Crohn's disease. So these are the important differentiating features on imaging between tuberculosis and Crohn's disease. So primarily, first coming to site of involvement, intestinal tuberculosis most commonly tends to be centered on the IC junction, with involvement of the terminal ileum as well as cecum. So the center is towards the ileocecal junction. On the other hand, Crohn's disease commonly tends to involve the distal ileum, tends to spare the cecum. On the other hand, left colonic and rectal involvement are more common in Crohn's disease. Regarding the number of segments involved, as already talked before, ileocecal tuberculosis is an oligosegmental disease, so usually less than 3 segments are involved. On the other hand, Crohn's disease is a multi-segmental disease, so more than 3 segments are involved. The length of strictures are longer in Crohn's disease and short in tuberculosis. Mural stratification is the stratification in the enhancement pattern seen on CT that is seen more commonly in Crohn's disease. Crohn's disease tend to be asymmetrical in that there is more involvement of the mesenteric side as compared to the anti-mesenteric side. So that results in a finding known as pseudosacculation. A very important finding to note is that tuberculosis tends to have necrotic lymph nodes that result secondary to coalescence of caseous necrosis. Mesenteric fat proliferation and increased vascularity are more commonly seen in Crohn's disease, as are features like fistulizing disease and perineal disease. On the other hand, enteroliths and ascites are more commonly seen in tuberculosis. So the important points that we need to remember is the length of the segment involved and also the presence of necrotic lymph nodes which favor tuberculosis. So these are typical imaging findings. So in this coronal CT angiography, we can see there is marked irregular thickening at the cecum, ileocecal junction and the terminal ileum. So the inflammation is centered at the ileocecal junction. So these are the axial images which shows a very homogeneous pattern of enhancement within this thickening. And also presence of necrotic lymph nodes. So all these are actually chain of necrotic lymph nodes. They all show peripheral rim enhancement. So this also favors tuberculosis. Then other features such as presence of bowel clumping with an enhancing layer of peritoneal thickening around it, which is known as an abdominal cocoon. Presence of omental thickening as well as ascites also favor tuberculosis because it tends to have a peritoneal component. These are enteroliths. So this is a stricture in the proximal ileum, proximal to which there are enteroliths. So this favors tuberculosis. And also chest X-ray. Chest radiographs are very useful. So if you find features sensitive tuberculosis and chest radiographs are very good supportive evidence. We these days also use a lot of CT, especially in cases of suspected Crohn's disease before initiating infliximab. So these are the typical imaging manifestations of Crohn's disease. So it's a multi-segmental disease. We can see multiple segments are involved here. They are a long segment. So here we can see a case of terminal ileal involvement. So it's reaching up to the ileocecal valve but not involving the cecum. So this is the mural stratification that I just talked about. So you can see a layered pattern of enhancement with mucosa showing more enhancement and the muscle showing hypodensity. That's due to submucosal edema. In Crohn's disease, we can also see marked fat proliferation around the involved bowel segment as well as prominent mesenteric vessels. So although these findings are also seen in tuberculosis, they are more common in Crohn's disease. Other features include the pseudosacculation, which arises due to asymmetric bowel wall involvement. So you can see the sacculations arising from the antimesenteric side of the bowel. In addition, presence of enteroenteric fistula also is more commonly seen in Crohn's disease. So here we can see a stellate pattern of bowel configuration where the bowel loops are tethered to each other with soft tissue intervening. So CT-based enterography has shown to add supportive value or complementary value to endoscopy in the differentiation of Crohn's disease and tuberculosis. The departments of radiology and gastroenterology have published several papers in the differentiation of both diseases. This is one such paper by Kelly et al., which evaluated several morphological features and then came up with a predictive model in the differentiation. Then Kelly et al. Also had done a systematic review in the differentiation of Crohn's versus tuberculosis and found that lymph nodes with necrosis is almost exclusively a feature of tuberculosis. Then, as I already said, increased mesenteric fat is also seen in Crohn's disease more than tuberculosis. So we tried to assess whether the ratio of visceral fat to subcutaneous fat showed any difference between Crohn's disease and tuberculosis, and we found that a higher proportion of visceral fat, more than 0.63, suggested Crohn's disease. So this is the estimation of subcutaneous and visceral fat. So the part which is outlined in violet is the mesenteric fat in the first panel, and the part outlined in violet is the subcutaneous fat, and the ratio was found to be significantly higher in Crohn's disease in comparison to tuberculosis. Then we've also done other studies where we combined quantitative features of visceral fat to subcutaneous fat ratio as well as long segment involved, and found that the combination of both features is exclusive to Crohn's disease. So in conclusion, imaging is very helpful in the differentiation of TB and Crohn's disease. Very often we find useful features. So MR and CT enterography are the most common modalities which are used. So the typical features in tuberculosis are short segment involvement, inflammation centered at the ileocecal junction, the presence of necrotic lymphadenopathy. The other in Crohn's disease typically has long segment involvement, multi-segmental involvement, and mesenteric changes in the form of fat proliferation and increased vascularity are more common with Crohn's disease. Also, the lymph nodes are non-necrotic, tend to be small in Crohn's disease. But however, we say very often it's very difficult to distinguish between the two entities, despite all modalities, and in such cases, an empirical trial of ATT might be required. So in future holds a lot of promise. We are trying to develop predictive models, and we are trying to assess several new paradigms like elastography as well as texture analysis in the ability to differentiate tuberculosis from Crohn's disease. Next, I invite Dr. Sudhir to give us part of the presentation.
Thank you, Dr. Rajit. To summarize the important features of histology and radiology, large case-shedding component granuloma suggests favors tuberculosis, whereas long segment involvement favors Crohn's disease, and presence of necrotic lymph nodes and permanent tuberculosis favors tuberculosis. But all these features they are not seen in every patient. So there are some significant portion of patients in which it is very difficult to differentiate from Crohn's and tuberculosis. Over a period of time, we looked at some other ancillary tests and serological tests to differentiate between Crohn's and the intestinal tuberculosis. And first of it, we looked at TB PCR in the mucosal biopsy samples, but it has a very less sensitivity, and the specificity is also less because other members of the mycobacterium tuberculosis complex can give positive test, and it cannot be used as a standalone test, as it is also we also recommended same in index TB guidelines which are formulated from our institute. And the next PCR-based investigation is the expert gene expert test from the mucosal biopsies. As in this study from this center, you can see we demonstrated very high specificity of 100% gene expert test using biopsy samples, but sensitivity is very less. So, the positive test can indicate a rule in a diagnosis of intestinal tuberculosis, but negative test cannot rule out the diagnosis of intestinal tuberculosis. We all the same has been confirmed in the recent systematic review meta-analysis involving 25 observation studies, also showed similar findings. So we also looked at serological markers like anti-saccharomyces cerevisiae antibody and AIIMS, and you can see that these serological markers can be elevated in both Crohn's disease and ulcerative colitis, Crohn's disease and intestinal tuberculosis. So they cannot be useful in differentiating these two. Even though the full sensitivity and specificity of interferon gamma releasing assays is around 80%, but these tests, including tuberculosis skin test, they cannot differentiate between infection and active disease. So they cannot be used as a standalone test. They should be used in conjunction with other parameters like clinical, endoscopic, radiological test. And positive test they cannot alone, it cannot rule in a diagnosis, but negative test cannot rule out a diagnosis. So there is a potential need for a new biomarker. In the process of identifying a new biomarker, we did a genome-wide gene expression analysis in 2015, and the interesting finding was the mucosal biopsies of samples of intestinal tuberculosis when compared with the Crohn's disease patient, FOXP3 gene was upregulated. FOXP3 is a short form for Fox and Box P3, which is a transcription protein, which is a marker for T regulator cells. T regulator cells are a subset of CD4 cells, they negatively regulate inflammation, they control the inflammation. So subsequently, we looked at the previous studies, and previous studies showed that in inflammatory disorders, the peripheral blood COX-P3 CD4 cells are significantly decreased compared to healthy adults. Whereas in pulmonary infections like pulmonary tuberculosis, the fraction of CD4 subsets of cells are significantly increased compared to the healthy adult. This is one of the mechanisms how the infections escape the attacked by the immune cells. So we formulated hypothesis, and we looked for the first time we looked at fraction of the COX-P3 T cells in the peripheral blood in patient and compared in the patient compared between patients with Crohn's disease as well as its intestinal tuberculosis, and we demonstrated a very high diagnostic accuracy with a cutoff of more than 3.5% COX-P3 T cells with area under the curve of 9.9 and with high specificity of 90% with sensitivity of 75%. So we subsequently we validated our findings in a recent study and separate cohort in which also demonstrated similar sensitivity and specificity. And with these findings, we started using this COX-P3 analysis in our regular clinical practice in our so with these microbiological tests like positive AIIMS culture, gene expression, they confirm the diagnosis, and regulating COX-P3 adds on to the previous other features like clinical endoscopy, institutional features, and radiology. And now I would like to invite Dr. Saurabh for.
Thank you, Sudhir. So, we have discussed till now about the various diagnostic modalities which can help us in differentiating intestinal tuberculosis and Crohn's disease. However, as admitted by other speakers, these tests are not always helpful, and in a proportion of patients, after all these investigations, we are still not biased and we are not clear whether the patient is or Crohn's disease. So, in this scenario, we need to start the patient on treatment. And between tuberculosis, between the treatment for tuberculosis or treatment for Crohn's disease, we start off the patient on anti-tubercular therapy because of the risk of dissemination of TB if the patient is started on immunosuppression. So, how do we follow these patients and how do we further make a diagnosis was evaluated by us in this paper in 2016, wherein we evaluated a cohort of patients with Crohn's disease. Of 350 patients with Crohn's disease, 150, that is about 1/3 of patients with CD were diagnosed after an ATT trial, and the disease course of these patients was compared with equal number of patients with confirmed intestinal disease. So, interestingly, what we found in this study was that after 3 months of ATT, up to 40% of patients with Crohn's disease also had a symptomatic response, which was sustained till 6 months of ATT. Obviously, more than 90% patients with TB had a symptomatic response, but when we compared the endoscopy and when we repeated the endoscopy at follow-up of 6 months of ATT, then we saw that all patients with tuberculosis had healing of the ulcer, had mucosal healing. But when we looked at patients with Crohn's disease, then less than 5% of these patients only had mucosal healing. So even though 40% patients with Crohn's disease had symptomatic improvement, a minority or a very minor fraction of these patients had mucosal healing, while patients with tuberculosis had clinical as well as endoscopic improvement after ATT. So based upon this, we devised this diagnostic algorithm. That is, in a patient who started on ATT, in a patient who responds to ATT, we repeat the colonoscopy at 6 months, and if the patient has mucosal healing, the diagnosis of TB is confirmed. In absence of mucosal healing, the diagnosis of Crohn's disease is considered. However, if the patient is not responding to ATT, we repeat the endoscopy as about 2 to 3 months of ATT, and in the persistence of active lesions, the possibility of Crohn's disease is considered. However, there is one caveat to it. In a patient not responding to ATT, in a patient with active disease of ATT, can this be MDR? Like we consider this scenario in patients with pulmonary TB. However, as we discussed earlier, that intestinal TB is a post-acidity disease, so chances of MDR TB are low in this situation, as we and others have demonstrated that the prevalence of MDR TB in patients with intestinal TB is as low as 2 to 5%. In our study, we could not demonstrate any evidence of MDR TB in our cohort of patients with intestinal TB. So, in a patient who started on a therapeutic ATT trial and is not responding to ATT, the chances of MDR TB are low, but still we recommend to repeat multiple biopsies and set them for culture before we diagnose the patient with Crohn's disease in presence of active disease. So, in a patient with CVTB dilemma, we start the patient on ATT. At 2 to 3 months, we evaluate the patient. We have been evaluating the patient clinically. In the absence of clinical improvement, we repeat endoscopy, and in the presence of active disease, the possibility of Crohn's disease is considered. If the patient is improving clinically, we repeat the endoscopy at 6 months. In the presence of active disease on colonoscopy at 6 months, again the diagnosis of Crohn's disease is considered. In the presence of clinical and endoscopic improvement, the diagnosis of intestinal tuberculosis is confirmed. As discussed by Dr. Razik, that a proportion of patients with intestinal TB may have pulmonary TB. So we also extended this observation and we did CT test in our cohort of patients with suspected intestinal TB. And interestingly, we found that in patients who had suspected intestinal TB, up to 1/3 of these patients had evidence of active TB on CT test. And addition of CT test to our diagnostic algorithm increased the sensitivity of diagnosing TB from 25% to more than 50%. And based upon this, our findings, the recommendation has been endorsed by the Asia Pacific as well as Indian guidelines for diagnosis of Crohn's disease, and both have recommended a trial of 8 to 12 weeks of ATT in patients with CDTB dilemma and a re-evaluation at 8 to 12 weeks when the patient is started on a therapeutic ATT trial. So, extending this diagnostic ladder, when we are not wise after clinical, endoscopic, histologic, radiologic, or microbiological test, we resort to a therapeutic ATT trial. The diagnosis of TB is confirmed in the presence of symptomatic improvement and mucosal healing, and diagnosis of Crohn's disease is considered when there is no mucosal. To proceed further, I would like to invite now Dr. P. Thank you.
Thank you, sir. So, it has been emphasized by Dr. Saurabh in the earlier part of his talk that we are at the epidemiological crossroads. We have both TB and Crohn's disease existing in our country, and although diagnostic algorithms have improved and we are identifying these patients correctly, but still there is a lot of confusion and there is a lot of enigma. On above this confusion of TB or Crohn's, now we have started to see a new subgroup of patients which are TB on CD. That is, on treatment of CD, patients tend to develop tuberculosis. So, anti-TNF monoclonal antibodies which are used in the treatment of Crohn's disease. TNF basically helps in granuloma formation and confines the bacilli. Use of anti-TNF poses a risk of development of tuberculosis, reactivation of latent tuberculosis in these patients. So, this study from our center, this was a study from our center which showed increased risk of TB reactivation, that is almost more than 10% of patients on starting biologicals in patients with IBD develop tuberculosis, and almost majority of them develop tuberculosis within first 6 months of initiation of infliximab. The important point to note here is that majority of these patients were screened for latent TB, and then the biologicals were started. Still, more than 10% developed tuberculosis. Now, as compared to the Western countries, in our country there is an increased burden of tubercular reactivation. So this posed a question, and to answer this question, this meta-analysis was conducted, from our center, which included more than 1 lakh patients, and of which 373 developed tuberculosis. The most important factor that came out in predicting the risk of development of TB was the local TB burden, and it was independent of the type of disease or the type of treatment the patient was receiving. And so India is a country with high TB burden, and as it has been already told that Crohn's disease is also increasing in our country, so use of biologicals is also increasing, and the risk of reactivation of tuberculosis is also increasing. So to tackle this problem of reactivation, we have been doing this. We have taken 2 steps regarding this reactivation problem. First is we have started to evaluate predictors of development of TB over last 1 year in patients who develop TB on biologicals. Secondly, we have made our latent TB screen more stringent. We have included, we have been doing CT checks in all the patients before starting biologicals. So, as a result of which only 1 patient in the last 1 year have developed tuberculosis after starting biologicals. Plus, all the patients who were screened for TB and were found to be having latent TB, they were given LTB prophylaxis. None of them developed tuberculosis in the long run. So, and next I would like to invite Dr. Srikanth to continue the talk.
Thank you, Piyush. So, all said and done, in spite of all the clinical indicators and biomarkers that we may have had, we know now that we have to give ATT trial to up to 1/3 of the patients. And it is reasonably easy to understand that we cannot give steroids to a patient with tuberculosis because he will worsen. But does this seemingly benign course of ATT trial have an effect on the patient? To study this, we performed a few studies.
This question actually first came into my mind when this study was conducted. It was suspected and it was well believed that tuberculosis strictures should improve with ATT. But what was actually observed that after ATT is also, the patient continued to have strictures. Although they improved clinically, they stopped having weight loss. However, the stricture persisted and there was sort of a fibrosis. In fact, only up to 1/4 of patients showed a complete resolution of stricture. And this was the persistence of stricture was more so in colonic disease. As we can see, there was mucosal healing, but the stricture persisted. So this led us to frame a further question that does this happen in all patients and what was the reason? Is ATT somehow responsible for this? So for this we analyzed 760 patients of Crohn's disease and divided them into patients who received ATT trial for diagnosis or those who did not. They were matched into two cohorts of 79 based on propensity score based when they were matched for disease location and behavior. They were matched for this because these are the two factors which predominantly have a role to play in the natural history of disease. What we found that the patients who received an ATT trial had a much higher proportion of stricturing disease on follow-up as compared to those who did not receive ATT trial. And on regression analysis, ATT was the most significant predisposing factor which led to stricture formation with an odds ratio of 11. This was very surprising to us, and a subgroup analysis of the same data almost was done, wherein we also compared for surgical outcomes. Surgical outcomes were also found to be much worse in those who had received ATT, and over a period of 14 years when the data was extrapolated, we found that patients who received ATT trial would have a much higher proportion of undergoing surgery, up to 75% over 14 years, as compared to 55% in the non-ATT arm. So we definitely are sure that this ATT course is not a very benign treatment in patients with Crohn's disease, so this trial should be taken with a pinch of salt. The next question came in that we know that 40% patients respond to ATT. What happens to those who don't respond? Do they perform differently or do they perform similarly? So patients with Crohn's disease who received ATT trial and responded or did not respond. Based on this, we divided into two groups and we found that no baseline variable of disease could predict whether a patient would respond to ATT or not, and there was no difference in the long-term outcomes between both arms. So the early response is not indicated that the patient is improving, and those complications of surgery and stricture would probably hold true even in responders. So based on this, we feel that the previous algorithm that has been discussed, there is some modification, although we are implementing it and validating it, we feel that there is a role of interval endoscopy even in those who are responding. In those who don't respond, definitely endoscopy is warranted at 2 to 3 months. But even those who do respond, endoscopy should be repeated at 2 to 3 months, we feel. And if there is non-response of mucosal lesions, then they should undergo a revision of diagnosis and clarification. With this, I'd like to revise the diagnostic ladder that we have. Clinical parameters which were discussed initially, mucosal symptoms like diarrhea, PR, bleeding, perianal disease with fistula formation, longer duration of illnesses, and extraintestinal manifestation favor a diagnosis of Crohn's disease. Endoscopically, multi-segmental involvement with left and right colon involvement favor Crohn's disease with deep longitudinal ulcers and cobblestoning of mucosa. Favoring ITB is ileocecal centric disease with transverse ulcer or circumferential ulcers. Histology-wise, the sign on con of tuberculosis is either AFB is seen on histology or there is large caseating confluent granulomas, while microgranulomas tend to point towards Crohn's disease. Radiological markers have already been shown that long segment involvement with neural enhancement, more mesenteric changes, and visceral fat favor Crohn's disease, while active extrapulmonary or pulmonary tuberculosis will favor tuberculosis, and necrotic lymph nodes have also been shown to be 100% specific. Positive AFB culture and gene expert, of course, leave no doubt in our mind that they are tuberculosis, but in cases of indeterminate cases, ancillary tests like FOXP3 can give us a good clue, and we are practicing them routinely in our clinics with good results. If all is not good, then we need to go for an ATT trial and early mucosal assessment, not radiological as of now, but early mucosal assessment is definitely indicated if the disease is accessible by endoscopy. With this, I'd like to call Anil sir.
I think we have 2 minutes, so I'll just run through a real case just to see that if we apply the diagnostic ladder, how does it help us? Like, this is a case we presented to us, 28-year-old male, case of neurofibromatosis, 1 year history, and short history, perianal costostart, pain in perianal area, 3 months history of diarrhea, he had diarrhea, hematochezia, fever, loss of weight, incontinence of stools for 1 month. Colonoscopy done showed ulcers with a deep transverse longitudinal in rectum. At the same time, there was involvement of the ascending colon also. There was an ulcerated stricture in the ascending colon. An MR ectography was done and the MR pelvis was also done. MR pelvis showed that right ischiorectal fossa collection was there, and subsequently it was seen that it was communicating with the rectum with the sinus tract, suggesting that okay, you have not only involvement of the colon, but you have something which is going on to develop a perianal fistula. So if you look at this case and now put all the symptoms against the diagnostic ladder, this is actually for the PGs, which I hope are logged on to this session. So is that you have patient with hematochezia perianal, clearly favoring cholestasis. This is how you evaluate a case. You have left and right colonic involvement, so this clearly favors Crohn's disease. Mark the word favor. We have not used the word, it is diagnostic. It favors because none of them is an all or none. None of them is absolute. Chronic inflammation, biopsies did not make us prove-wise. Perianal disease on radiology suggesting that it was favoring Crohn's disease. So we did not do a FOXP3 in this patient at that time. So based on this, what one would do is make a diagnosis of Crohn's disease, and in such a kind of disease, one would have to start biological therapy, that is in the form of TNF monoclonal antibodies or something like that. However, before starting monoclonal antibodies, anything before that, we again went over the algorithm. That is what we do. Is there some way you make a mistake? You just double check. So if you go over it, what is the mistake you think you could have? Actually, there's one thing, because you have to, that is the art of diagnosing Crohn's. It's a mathematical formula. You just go linearly over everything, and if you go linearly over everything, the chances of mistake are very less. We had missed a CT test in this case, and we went ahead and did a CT test, and the CT test clearly showed this patient had tuberculosis. Actually, all the manifestations in the colon, the perianal disease, everything was part of tuberculosis, and this patient did very well subsequently with antituberculosis. So finally, as we saw that most of the people are presenting, it was like work done by the whole team, and it has radiology, pathology, GI, surgery, microbiology, we have a collaboration and all. But the most interesting part which I see out here is that 90% of these studies did not require any funding. It's an example of non-funded clinical research in solving a question which is specific to a particular region. Except for one FOXP3 part which required a little bit of funding, or the other paper, the M1 and 2 macrophages, that required a little bit of funding, otherwise majority of it did not require funding, and they were all actually theses of all the DM students. Systematically, one by one, DM theses were given, and that led to, in some ways, I can say that we have not cracked the problem, but at the same time, it has made us wiser over the last 10 years. Thank you very much. Now, before I open it up for questions, I would like to invite Professor Piyush Tani, Professor Raju Sharma for their comments.
So I think Razik has adequately covered the role of radiology. Just in addition, that the relationship between gastroenterology and radiology is like a matrimonial relationship. Expectations are very high, and we never satisfy each other. So, and in this particular challenging problem, it is especially so because it's a very difficult question to answer. A word of emphasis on the way we image the small bowel in today's time. We still see patients coming with follow-throughs from done at other centers. I think follow-through is a dead investigation, should not be done at all. It needs to be emphasized that we need to do a CT angiography, and for all follow-ups, do an MR angiography. It's not a very technically demanding procedure and can be done at majority of the centers which have a spiral CT. All centers now have a spiral CT. If they have a CT, it's all ND-CT, and it can easily be done anywhere. And as far as the points of distinction between the two entities, I think they've been adequately covered by Piyush.
But my question to this, are you very sure when you see in terms of diagnosing, how sure are you saying that?
That would vary from a case-to-case basis. There are patients where we are reasonably sure that this is Crohn's, and we would even say start immunosuppression. You don't need to do anything else. I think that happens when we are seeing an advanced fistulizing stage of disease with associated extraintestinal
So I think it was an excellent presentation, which all of us have seen. Dr. Ahuja in the beginning said windows are limited. I think 25 years down the line, faculty in Department of Gastroenterology will surely say that they did an excellent job to decipher this very complex problem. I think there's huge consistent work over the last 15 years or so, paper after paper, so that has been recognized what it was. I think congratulations to the entire team. So I have two questions. One is, in terms of histology and radiology, it seems to me if you have a AFB or a culture, surely you say this is TB, but that is seen less than 30% or about 25%.
Yeah, 30%.
So in those cases where you don't see 75%, does radiology score histology in general?
Yeah, everything adds up. So if you go according to the diagnostic ladder, everything is supplemented. So you have something, you add on something, so you add on something, still there 20% is left, then you add on. So that's why we're trying to close the gap with the help of OxT3. Then secondly, we're trying to close the gap again with the help, like CT test help us in further closing the gap. Now what we are doing right now, which we didn't show out here, was that we are in the process of making an ITP-CD app, where we feel that by making all the parameters, using a little bit of mathematical modeling, if we just put in the parameters out there, it gives you a probability, 90%, 95%. Because apart from that, till now, I don't think there's going to be anything further unless we get some really new good parameters.
So that brings me to a second question, but I would like to put my money on radiology if case.
Okay, then let me tell you the radiology story. You saw Saurabh's papers, so that was Saurabh's VM thesis. There were two best radiologists in the country, I would say, not country, internationally, who could solve this problem. Because the Western people, they do not see this anatomy, you know, there's a CPC. That is Madam Nagi at PGI Chandigarh and Dr. Rahul Sharma. So what Saurabh did, I also went along with him, we put 200 case files on the top of a car, went to Chandigarh. Dr. Nagi saw all the cases, spent 2 days, and then again another 2 days, whereby she scored all of those, all the CTs. Then Dr. Rahul Sharma out here, blinded to Dr. Nagi's observations, went through it. And when we collected all the data, still we could not find out anything else except lymph node necrosis as an all or none observation. Fine, Crohn's side, you'll see more in Crohn's disease. But in TB also you would say, here it's not a question of statistics, it's a given patient. In a given patient you want to decide, it is TB or CD, because it will start treatment. So there was nothing out there. So only except for lymph node necrosis you could not find. So CT, MRI subsequently also seen, and studies are still continuing. That is why you have the distal fat and all those kind of studies which came up. But they are providing probability. What we want is an absolute,
which is difficult. And
but that's nonetheless we still run up to Dr. Rahul Sharma the moment we get certificate. That is the kind of I would say the quality he has, and the moment he feels it is that bears our decision.
Yeah, for other diseases as well. The second point is about this toxicity. I think this is very interesting. Do you think you are likely to find with more data, more refined technologies, a immunological signature of a particular disease? Because fundamental difference to either an infectious disease or autoimmune disease would be different. So in addition to toxicity, it would be like a
toxicity is giving us good discriminative value. Right now, for example, I just looked at last 27 cases of Crohn's disease. They picked up 26 out of 27.
That's what I'm saying.
In tuberculosis, it was a little less, but overall, of all the cases, 80% has a single test it picked up. And we are doing it regularly now in our OPD, and we are planning to make it thinking of how to make it a point of care test so it can be done at other centers. But then we have done 3 validation studies now for toxicity. It is not just a.
No, the only thing is that you had 44% versus 23% toxicity in the blood. So, I mean, discriminating value is there, but I think in addition to this, if you add 1 or 2 other parameters, it becomes a signature.
So, that is where the TB-CD app comes.
Right.
That you add on various parameters and if it then listen.
Thank you.
Are there questions from the chat box? Especially here.
There could be questions on the chat box.
Please, chat box.
So there's no question. Okay. Thank you everyone.